Good morning, everyone, and welcome to this meeting of the Social Affairs Policy Review Committee. I'm Anne Caller, MHK, Chair of the committee, and with me is Mr Tim Glover, MHK. So today we're meeting with the Minister and officers from DHSC and officers from Manx Care. So for the benefit of Hansard and anyone listening, could you please introduce yourselves, including your title and how long you've been in post? Should we start with Professor O'Neill?
Thank you, Chair. I'm Tim O'Neill. I'm Interim Chief Officer for the Department of Health and Social Care. I've been in post nearly a year.
My name is Claire Christian, MHK. I'm the Department of Health and Social Care Minister, and I've been in position since December of 2025.
Good morning.
4 even. Sorry, 4.
Good morning. I'm Teresa Cope. I'm the Chief Executive of Manx Care. I came into post in December 2020 as Chief Executive Designate, and I've led Manx Care for the last 5 years since April the 1st, 2021.
Good morning. I'm Natasha Wilson, Non-Executive Director for Manx Care, and I've been in position for about 6 weeks.
And good morning, my name's Sean Stacey. I'm the Interim Director of Operations for Manx Care. I've been working with the department and Manx Care for the last 19 months.
Thank you. Well, welcome to you all. And we have quite a lot of questions, so we'll keep our questions concise, and hopefully you can keep your answers concise too. So we'll start off with some questions around the department plan, operating plan and Manx Care mandate. So, first question is, what evidence demonstrates that the 26-27 Manx Care mandate addresses the problems and failures of the 25-26 mandate rather than just re-articulating existing ambitions?
So, I think that without sort of regurgitating what we discussed in the PAC last week, I think probably the first thing is to say there was very big differences in terms of what we have put within this mandate, in the sense that everything is funded. We absolutely strictly wanted to make sure that that there was nothing in the lessons learned from the 25-26 mandate where not everything was funded due to transformation funding or additional business case funding or other out external reasons, whereas I probably would say the biggest fundamental lessons learned difference of that would be that the 26-27 we were absolutely sure that anything that went in that mandate was funded, and if it wasn't, it came out before it was published, and with the view that we would bring something back later on when we did have Treasury concurrence, but we worked exceptionally hard as the board and also Manx Care and also the department to make sure that this was more realistic.
I would echo that. So we did receive a 12% uplift, and in 25-26 we talked about there being a number of services which we had specifically put outside of the operating plan, indeed the mandate. They were recognised, they were not within the quantum of the £361.8 million that Manx Care received. And indeed the £10 million contingency. So those services which were funded or not included in the 361.8, and indeed the cost pressures which were used and funded by the Treasury contingency, all then came through into the baseline position, so the 404. There are still a couple of areas, but actually, as we recognised in the PAC last week, we're much closer to knowing that all of the funding lines in the mandate and operating plan do have a funding stream. I think there was significant learning from the sort of the 25-26, where I think in best endeavours we were very clear about what the 361.8 funded and then what sat outside. But during the course of the year it became increasingly difficult to address the funding of those through other routes, and therefore it was appropriate that DHSC and Manx Care took the approach that actually we will put all of that into the baseline. Let's not try and have to go back for additional funding in year for anything which we haven't captured in the mandate.
Okay, so you said there's a couple of areas there. What specific areas are an exception to the funding?
So homelessness is an exception. That was a late addition into the mandate and operating plan, and that is going through a process through the Housing and Communities Board to receive the funding, both in terms of the team, the homelessness team, which sit within Manx Care, but also the costs of the emergency accommodation. So it is a substantial amount of money, but I think we're as confident as we can be that there is a process to make sure we do receive that money in. The other aspect is ensuring we have the rollover of transformation funding. As we discussed again last week, the 25-26 mandate and operating plan were highly predicated on receiving transformation funding. So a lot of assumptions were made around the use of non-recurrent transformation funding, which did not materialise until month 11. And again, we have sought the rollover of that transformation funding into this year, I think that has been resolved in recent days, and we're just waiting for the cut-up of the Treasury minutes to confirm that before we can then start.
Thank you. So the mandate does acknowledge workforce pressures. So how do the additional delivery expectations in the 26-27 mandate align with current staffing levels?
Yeah, so there's been some very specific pressures. Overall, I think Manx Care has been successful in reducing the number of vacancies it has. So we're definitely between 8 and 10% below where we were 5 years ago. The vacancy rate has dropped. But also we have identified some significant cost pressures along the way around safe staffing. One of the areas that was particularly pertinent in 25-26 was that there was a Royal College of Physicians review of medicine, which identified we had substantial gaps in our medical workforce at all levels, at consultant level and at junior doctor level. And the board, consequently, because the deanery, the Northwest Deanery, were involved in this piece of work, because obviously they have to have the oversight and the governance of doctors in training. The Manx Care Board, supported by the DHSC, agreed investment, in-year investment, to be able to increase the number of medical staffing. That did place quite a substantial cost pressure into the organisation, and that's what we've worked through during the financial planning for this year. It was one of our key business cases, and it was one of the priority investments against the 404. I'll probably hand over to Mr. Stacey because he has much more detail about this particular pieces of work or any of the workforce pressures that we have that have incurred additional cost.
Yes, thank you to the Chief Executive. So what I would build on there is that the main pressures were in the support for general medicine. There had been a long period of time where general medicine was reliant on temporary doctors undertaking the activities to support the demand generated mainly through the emergency department, so people presenting in the emergency department and requiring ongoing care. And so with the board's consent, we set about trying to move away from employing significant numbers of temporary doctors at every grade, so consultant and hospital grade doctors, and converting those as appropriate, so not to grow the workforce beyond where it was needed, but matching the demand of activity. We have set about recruiting to those posts, which we've managed to do, which has then reduced the overspend quite considerably. We were heading for north of 8.5 to 9 million on medical workforce alone, and we were able and have been able to mitigate that. And then, of course, recurrently this year, with the support from the Department and Treasury, we will be able to continue that mitigation, but we also have enough doctors to support the activity. We also, with nursing, took quite a significant approach in reducing the temporary, so again, agency nursing workforce and the use of bank. We haven't fully mitigated the bank, so there is still a demand to support peaks and troughs in activity that is presented to us through the bank. But we have virtually, without exceptions, so there are exceptions, so TT, for example, there are exceptions where we need agency numbers, but apart from that, we have reduced agency workforce. In social work, we've actually utilised the benefits of having temporary workers. It's quite difficult to attract social workers, a bit like neonatal nurses and midwives, but one of the ways of attracting them to the island is to bring them here, give them a really good experience, and then we've been able to convert those individuals into substantive posts. So again, a short-term pressure, but actually it resulting in a reduction overall currently, and we have, we're planning to continue that till we've completely closed out all of those temporary staff. As the Chief Executive has said, we have brought down our workforce vacancy rate quite considerably over the last 12 months. There are some workforce pressures, though, that will continue, and we are working closely with the department, with staff side representatives, with the BMA, on how we can adjust the shift pattern irregularities that present here. So on the island, doctors do not work in a prospective cover way. That basically means that within their annualised hours, within their annual contract, their out of hours work is also included, and so that is always paid for as additionality on top of their baseline pay. And so we are working very closely with them and other staff side unions to try and set a balance there and bring us more in line with normal pay to help control some of that currently uncontrollable spend.
Okay. Just, I'm assuming that some level of bank staff is of benefit to you to provide the flexibility.
It is absolutely. It's really important in two ways. It's really important in two ways, Minister. The first thing is that actually that's very attractive for our staff. There are people who want to work in a flexible way. They have family commitments. They may have other business commitments, but actually having them available to us both in social care and in healthcare is really, and in medicine is really beneficial. So we will always have an amount of bank. And as I've already described, short notice sickness, annual leave planning can be supported by having bank staff available, and peaks in activity. So the hospital and community services see peaks in activity and demand, and so peaks in activity and demand are managed very effectively by having that flexibility and that flexible workforce. So we wouldn't remove the bank. Yeah. It's the high cost agency that we're really focused on, and reducing the bank to where it's absolutely necessary.
Thank you.
Thank you, Chair. I'm going to go with items that have recently been in the news, never far from the news, Manx Care and Health. The urgent bed review that was undertaken, has that reported yet?
No, it's
how's it described as urgent then?
Thank you. So the I believe it's starting on the 20th of this week. There's already been some engagement last week, but we are committed to producing that report by the end of May.
Okay. There's also been quite a lot of concern raised recently about the, and indeed by yourselves, about the size of the emergency department. And Minister, in answer to a Keys question recently, you spoke about those improvements that you're intending to bring. You spoke about some immediate measures that would being brought in to help things out, and also a project development fund to support the next stage of work being approved by Treasury. Can you just give us some more detail about what that will cover and what the timetable is likely to be?
So for the different aspects, I'll probably pass to Sean, but just as an overall highlight to that, you've listed obviously the and Sean will attest to this, but the size of the current ED isn't fit for purpose. So yes, the PDF funding has been approved. that's going through the next stage, which Sean can update us on. And then with regards to the, we talked about the clinical decision unit. I understand, and again, Sean, correct me if I'm right, but I understand that's now, the position has now changed from the end of May to end of July. And this is due to the Ward 2 needs more work, and the DOI are working very fast for us to get that resolved, to get that ready for the clinical decision unit. And then I remember there was another 16 beds as well. You were looking into 14, sorry,
yes.
Looking at increasing that capacity. So I'll hand to Sean because he knows the more operational detail on that.
Yes, so thank you, Ministers. I mean, the emergency department is well under the size that it should be for the demands that it's seeing. So between 120 and 140 attendances in any 24-hour period now, with between 15 and 20% of those attendance numbers being admitted into hospital. Clearly, as the Minister has described, we need to get the authority to build a new emergency department, but really it's a front door. So it's not just a new emergency department, it's actually also building a new medical and surgical assessment unit, and also a sort of short stay urgent care facility for people who don't need to be in hospital longer than about 12 hours before they can continue their care in a, I'm going to describe it as an outpatient way, so they just come back to that clinical area for ongoing treatments over a shorter period of time rather than being in a hospital bed. We've already begun that development, and Minister, I know, has spoken about this with the development of something described as a clinical decisions unit that will support the ambulatory assessment and treatment unit that was opened, I want to say 2.5 years ago, and the growth and development of those units coming together, allowing better short stay emergency care rather than holding on to people in the accident and emergency department, which isn't really beneficial for them or for the department. And given the footprint is so small, it does create clogging up in the department, and you will be aware, the public will be aware, that we have at times been under immense pressure with the waiting room being much fuller than it needed to be. We're also going to almost imminently change that footprint temporarily by moving some clinical space around to allow the accident and emergency department to grow within its existing footprint. There are other services that are currently provided in the accident and emergency department, and we're going to move those shortly to enable some growth into that department, and the clinical team then can redesign the existing footprint. We can't go on until a building is put in place, trying to sustain the increasing demand in such a short and tiny space. And as Minister has alluded to, the development of the clinical decisions unit, it is very unfortunate that the flooring has required more extensive work than DOI had initially assessed when they assessed Ward 2 for refurbishment. As they lifted the floor, they found considerable problems, which has extended the build time, the refurbishment and build time. That will be, they assure us now, concluded by the end of July. That additional flooring work has already commenced. As I speak to you today, that additional flooring work has been commenced by the DOI through a rapid procurement process following government procurement guidelines. That will provide a much better front door service from certainly early August, and certainly going into next winter we should see a much stronger accident and emergency department. But until it's fully refurbished and fully rebuilt, I don't think the problems of that building will go away. It does require that investment, and so I really do hope that we've been able to do right by the design we've done with the clinical teams to develop this better front door. You will be aware that last year I spoke about the development of the acute medical model, so using the acute medical assessment unit for its due process, so 72 hours of emergency medical care and then getting people home. And I'm pleased to report that that is successfully operating now in that model. And the clinical decisions unit, which will has taken a 1.9 £1.2 million investment to create will deliver the next stage of that care, as I say, from August. That's complemented by the development of intermediate care and the development and enhancements within our community services, particularly with our advanced practice in district nursing. That combination, along with the services of the hospice and the development of social work, the hubs, should help us to manage the flow of work. The 14 extra beds that Minister alludes to is going to take a little bit more work, but once we've completed the Ward 2 refurbishment, we hope to be able to rejig the wards to create an additional 14 medical beds, particularly for during the height of winter when demands in general internal medicine increases quite considerably, and that we hope we will have available from November next year.
Just want to talk about demand, because you had to escalate to Opal 4 last week due to exceptional demand. Is that all related to what you've just given us in the previous answer as well? Because Opal 4 is basically about protecting services that are core to protecting lives, really, isn't it?
Yes.
Do you want to start? Yes.
So let me start. So absolutely, the Opal framework is a framework by which hospitals manage the demands on their services, and it enables them to manage rather than to fall over and end up not delivering any kinds of care and having people cared for in the wrong place, corridor care, etc. The hospital was under considerable pressure for the preceding 7 days, with demands through accident and emergency exceeding 125 attendances on a daily basis, with numbers of patients in the emergency department throughout the 24 hours ranging between 30 and 50 patients at any one particular period of time. Now that's quite different from what our normal profile would have been, which would have been between 25 and 40 patients a day.
And that's patients having to wait more than 12 hours, isn't it,
that's
as well?
That's patients waiting for more than 12 hours. So the numbers of patients that have been waiting for more than 12 hours consistently has ranged around about 12 patients per day. The remainder of the patients are getting seen and treated in under 4 hours, with 55% of patients attending the emergency department being seen within 4 hours and not requiring any further medical follow-up. That by its very definition asks us to look at why those people present at the accident and emergency department and why they haven't used one of the many other services provided by the island to access healthcare. So your pharmacist, the hubs, your GP and other service providers, so optometrists now who are able to deal with eye injuries through the changes that the service has made, dentists through the changes that dental access has driven. So we do need to go away and look at why that profile is so significant. On the 2 days of last week where it was particularly difficult, 280 patients presented in that 48-hour period to the accident and emergency department, with 60 patients being admitted to our hospital wards. That's a significant number of people being admitted to our wards and a significant number of attendances in the emergency department. That was set against an average of 20 discharges on each day. So as you can already hear, the number of admissions versus the number of discharges outweighed. And so it took us until Friday to recover from that period. We needed to create bed capacity. I just go back to, you don't want to be cared for in a corridor. You don't want people being cared for in a non-bedded, properly nursed, properly therapeutically supported environment. And so to do that, I took the very difficult decision, along with the clinical teams, so the clinical directors and the clinical teams, to stand down elective work, which immediately created for us 20 plus beds across the hospital site, because the surgical ward is ring fenced for elective surgery, and that released capacity, and the day patient unit is again ring fenced for elective capacity, and that was released by standing that work down. It's not comfortable for the 19 individuals that were stood down from their care. We retained cancer care because it would be inappropriate to stop that, and we retained paediatrics, and we retained all procedures that could be done and dusted as an outpatient procedure in the same day, where their need for staying wasn't particularly long. But for those 19 people, their care was stopped, and that's very regrettable, and they were notified either on the day, particularly on Tuesday afternoon, or within 3 hours of us making that decision.
What happens to them now? Are they still at the top of the list?
They are. They have all. I can confidently say this morning that 60% of those patients have already been rescheduled for surgery before the end of June, and the remaining just outstanding. We're just waiting to hear back from them. We will get everybody rescheduled within 28 days of the incident occurring, which is our standard access policy in these circumstances, and we will treat those patients. The one specialty where there is a complexity is orthopaedics. Because of the nature of the next 2 weeks, we do need to manage carefully how we treat those planned patients against the demands that the racing might make upon us.
You mentioned there that there were people attending the emergency department who really didn't need to be attending the emergency department. So how are you going to address that? And what other factors do you think were behind such a large demand at that time, at this time of the year?
So sorry, Minister, might I, because obviously it's important that we don't accuse the public of doing something that would be inappropriate. Mm-hmm. So if I may say, it will have been appropriate for those individuals to have chosen to attend the emergency department because they felt there wasn't other access. What we have to do is a public education programme on the island to ensure that the public know where other access is available. And I don't think we've done that strongly enough. I think we need to do that. I think we need to strengthen what happens in our community, strengthen the good news stories about what our GPs are already doing in terms of making sure that more access is available to their patients so that they can use alternatives, strengthen the opportunities that people have by going to the hub or seeking help from pharmacies, for example, or optometrists, for example. We need to strengthen that before we suggest that the public have got it wrong. I think at the moment it's Manx Care that needs to make that adjustment, along with public health and along with the department, in getting the communications right. We've made significant investment in the last 5 years on the island around healthcare can be accessed, but we still haven't got it right, because the public are still choosing one direction. So we need to help the public. I would not want it to be reported or recorded that members of the public have wrongly chosen. If you yourself feel unwell, accident and emergency is the place for you to go in any circumstances. I think the point is that for quite a significant number, 55% of those people that attended and attend every day, actually they go home from accident and emergency very satisfied. They've received the care that they needed, but there's no further follow-up needed, which means a healthcare professional other than an accident and emergency doctor, nurse or therapist is able to treat their care. And that's a national issue. It's not just an issue here on the island. I hope that clarifies that point for you. I don't know if my colleague would like to say something further.
So I think, going on to Opal 4 is very rare. But actually it is intended to ensure we run as safely as we can whilst being incredibly busy. So like any other Opal 4 situation, we will investigate what happened, sort of almost the special cause variation which tipped us into that position. We know from our benchmarking that the number of ED attendances per 1,000 population on the island is higher than Jersey and higher than England. And what we know through that period of Opal 4 was the conversion rate, so the number of patients attending ED who convert to admission, which is normally very consistently around 17 to 19% here, was double that. So something quite different was happening in our hospital last week, which caused that situation. So it is entirely appropriate that we undertake a thorough investigation so we understand how we can mitigate that what is the learning from moving on to Opal 4, and how we can prevent it in the future. But it's I would want to reassure it is an established framework to basically stand all of the tasks down and ensure we are all focused on managing the safety of the emergency department and urgent flow during that time.
Do you expect the reopening of the minor injuries in Ramsey to take some pressure off A&E?
It obviously will. We have increasingly pushed over the year to promote the use of the Ramsey MIU, and before it ultimately had to be closed because of the issues up at the Cottage Hospital site, it was seeing around 40 patients a day, so much better utilised. And even though we have moved those staff and we have staffed up in Nobles, there is still the physical capacity of trying to see those extra patients through. So it's welcome news that we're able to reopen the MIU at Ramsey, but we also do need to make sure it is appropriately and well utilised, given the substantial costs of reopening that service. It will help. It will help.
Okay. I think if I could just add, just interestingly, and speaking to some of the member of staff in the past, we have done an education process with when to attend A&E, and actually interestingly the results showed that more attendees came into A&E, so whilst education is absolutely really important, you can see obviously you're going out there to talk about A&E, it's going to raise that, and also I think, but just one other point in terms of the MIU, I think it has absolutely, obviously patients coming down to Nobles Hospital in that same location will have contributed over the past 3 to 4 months to the situation within Nobles Hospital, but I think that the Manx Care have absolutely, credit to them, where we were supposed to be back in very quickly up at Ramsey District Cottage Hospital. That hasn't been the case because of the extent of the works that has been not to their fault, and I think it's really important that they have done everything that they to acknowledge that they have done everything that they can to make sure that patients are still seen appropriately and safely, and that has been the most important thing. And in terms of last week, again, I absolutely, I completely understand how those 19 patients, I've heard personal stories about, they've been waiting for those operations for some time, and it's obviously hugely disappointing. But I think that if somebody needs emergency, remember this is what we're talking about, emergency care, that needed to take priority last week. And I think that was absolutely the right thing to do by the organisation, to step that plan up. And I believe it's been, Sean, correct me again if I'm wrong, in your 18 months, Opal 4 has been happened twice in that time. And I think if you look at the statistics in the UK, you're looking at a great deal more days. I think the average is, I think it's 20 or so for some of the NHS trusts. Some go into 125 days, I've even read. So it's a great, in 1 year, it's a great deal different. But again, that's not to say that's where we want to be. We absolutely want to make sure, and there's that learning, as Teresa has said, needs to be looked at, so that we don't have that scenario.
Thank you.
I think I would just add, Ministers, if I may. So coincidentally, with the timing of the Opal 4, we had planned, as we lead into TT, we had planned something called the Perfect Week. So it's a multi-agency discharge event that works with all of the health and care professionals across the island to look at how we are flowing patients through our system, not just the hospital, but through the system. As it happens, coincidentally, that commenced on Thursday and has successfully contributed to the discussions, the work, and identified some of the further challenges. So the learning that the Chief Executive has alluded to has already commenced, and through that process we've already begun that learning. There will be a proper debrief and proper learning event specifically for the Opal 4, but some of that work will have already been done through the Perfect 10 that's currently running.
Thank you. Mr. Stacey, you explained quite clearly how congestion in the flow of patients through A&E onto the wards is a problem. But how much is that impacted by the closure of Ramsey Cottage Hospital?
I think the congestion in the hospital is multifactorial. So there's no doubt that for Nobles Hospital, having to take on board the 20 patients from Martin Ward has hindered the flexibility within the hospital space to move things round. In addition to that, we commenced last year the refurbishment programme for a number of wards, the stroke unit, the new replacement for the emergency surgical ward, Ward 2 as was, and then the development of Ward 7, the elective surgical ward, making that better and more structured for an elective facility, and then finally the bit that we're in now, the development of the clinical decision unit. So constantly throughout the latter part of the year, through winter, one 20 plus bed space has been out of operation for that reason. There is no good time to do those things. In my 25 years experience as a chief operating officer, there's no right time to undertake that work. And in my utopia, I would have said, you're never going to do it, actually, unless you bolt me a new unit on the side. But that's hugely expensive to do, simply to give you a potential for mitigation. Actually, the hospital has managed particularly well, although the waiting room has swollen and has been under pressure, and up to 12 people at any one time have spent more than 12 hours in the emergency department. Some of that, though, is related to decision making around admission, because remember, our intention always now with the modern way of working is to look at getting somebody back home when hospital isn't the right place for them to be. And so we've put things in like our older person service in the emergency department to help our older people to get back home rather than them become admitted into hospital and then require ongoing supported care in a residential or a nursing home placement. We really want to try and keep people at home as much as possible. And there is a significant range of medical conditions now where actually spending time in hospital simply exposes you to other risks, and actually you're better attending a unit for that treatment and then spending the rest of your time at home. So with that in mind, we have managed particularly well. As ministers alluded to, we've had 2 episodes in the last 18 months of true Opal 4. We do have a very high run rate of Opal 3, and that is primarily due to the fact that we haven't had the flexibility we would have ideally liked. But we have kept people safe, we've not had corridor care. If I'm honest, and my appeal to the public, as always, as the operating person, is when we are planning discharge, help us to deliver that quickly. We still have a problem getting people home by 12 o'clock midday on their day of discharge, both into nursing homes, residential care homes, but also just getting people home into their own home. It's a real challenge. Now, we've got to work with everybody. It's really important that people go to work. Mum, dad, uncle, aunt might be coming home from hospital, but they've got to go to work. We have to work collaboratively together, but it's about how we can do that in a joined up way that really makes it work for everybody, because somebody spending unnecessary time in a hospital bed is somebody spending far too long in the emergency department or in outpatients waiting for that bed. No hospital has the luxury, and the Isle of Man definitely doesn't have the luxury of running at 45 or 50% bed occupancy. It would be very, very expensive. Remember, it costs as much to run on that occupancy as it costs to run on 95%, 85%. And we mainly run on 85, 86% bed occupancy, which is safe for cleaning and caring and supporting people. But help to discharge would be something I would implore the public and ministers to help support us with. And I think the other thing is making sure that we use our services in an appropriate way. So participating in social care assessments, participating in the decision to move on to the next level of care and support, again, is really important. We have long lengths of delay where people are being asked to participate in the assessment for social care need and social care support. Again, I really do understand how difficult it is to make that commitment. But remember that we, the department and Manx Care, have made a commitment to the public that we will support people for up to 4 weeks whilst those assessments go on. that should be enabling us to process and get people out of hospital sooner, but we're still not able to do it. So I think you've got that combination mix that results in the Opal 3 framework, and we're doing a huge amount of work around, again, public education, social services education, and understanding for clinical staff around how that can work better, and supporting the hubs in working closely with the charity sector and ourselves to get flow out of hospital right.
Thank you.
You mentioned, obviously, Opal 4 and a high-pressured situation within the hospital. We're going into a potentially pressured situation with TT Fortnight, really effectively beginning on Friday with racing at Boulogne. How prepared?
So we have signed off at the board and through the executive our plans, so we are prepared. The Chief Operating Officer, supported by the Director of Partnerships and Improvement, have led that piece of work. It has been through emergency planning. We are ready, as are our colleagues in Aintree, and I've spoken before about the importance of that pathway. You know, we have to staff up and be prepared within Nobles. And the wider system, because one of the things we always have to recognise and appreciate is the racing impacts on all of our community provision as well. So it's making sure we can still do our district nursing visits, our therapy visits, but Nobles is ready, and obviously we have got the agreement from Aintree. So we have signed off on in fact I signed it off this morning, the Memorandum of Understanding between Liverpool University Hospitals to make sure we have the right level of major trauma centre support, which again has increased again on previous years. And the costs have also increased because they are recognising that in order to support at the right level, they need to bring in additional staff and additional trauma coordinators to be able to support us. But we have signed off the plan and we are ready. And the plan is being published, so people will be able to...
That was just what was about.
Yeah, we have committed to publish it, so it will go out on the website this week.
Okay.
Thank you. So we'll just move on to waiting lists. So the last time we met, Ms. Cope, in November 2025, there were 1,500 patients remaining on the dental waiting list. Can you provide us with an update on the number today?
So I don't have actual today's number, but I've got more recent information. So we have made over 6,350 allocations from the dental waiting list since we made the contractual change last July and then started allocating that. Since that time, a further 2,786 patients have been added to the dental allocation waiting list. And so the waiting list at that time, and this is sort of at the close down, is just over 2,200. I think we did anticipate that when you allocate such a high number of patients to dental surgeries, those people who perhaps had been paying entirely privately for their dental care will then look to receive their dental care through the NHS, so will sort allocation via ourselves. There is no eligibility criteria for dental, so this is something we did anticipate. And obviously we're continuing to work hard. We're continuing to look at the impact of the contractual changes. What is positive in that we are seeing the units of dental activity being delivered increase, and dental providers who we are contracting with are now reaching their contracted levels of activity. So in previous years, there was always a gap between the level of dental activity, the units of dental activity that we had commissioned from our providers, and then what they were able to deliver, which resulted in us sort of clawing back that money, but in the following financial year, which then wasn't helpful. So we're getting much closer to our dental providers under the new contract delivering the units of dental activity they have been contracted to.
Okay. So, how do you plan to keep on top of new applications for the NHS practices? I mean, is there a plan to introduce criteria? How are you going to manage this?
I think it would be for the department to comment on whether we perhaps would start to consider eligibility criteria for dental services or do anything with the charging framework. But perhaps if I hand over to Sean in terms of how we plan to manage the operational piece in the here and now, and then perhaps back to the department for eligibility.
Thank you, Chief. So ultimately, we know that the demand again has gone up. We've got to balance that demand. So we are doing a piece of work at the moment which looks at what capacity we can create within the current financial envelope, within the current NHS dental services. As you will be aware, we currently manage Hillside and the community dental practice in Douglas, and the Hillside team are really keen to develop more capacity, but their physical space doesn't allow that. So we're working with them and the community dentist team on how we can make that work. There is enough space in that combined unit to be able to do that work, but we need to work through that. And likewise, you will be aware that we've had some difficulty with smile dentists in the north of the island. And so again, we're looking at how we can provide further NHS provision within our financial envelope in support of the dental activity that's needed for the north of the island to make that better. And we will have that work concluded by September, which we then hope we'll be able to open up some more slots, but that will be within the financial envelope. Clearly that won't solve the problem. As Teresa's just said, the way that the economics work, once we've closed and the waiting list has shrunk, more people will add themselves onto the waiting list. But that's where the department need to consider the criteria for access to NHS dentistry, and that will then hopefully share the market. But I do concur with Teresa, the new contractual arrangements with almost all of the dentists on the island has resulted in much better capacity, which is a great thing, and we're very grateful to them and their group for supporting the actions that we've taken in the last 12 months.
So yeah, absolutely. It's described in our department plan that we will be looking at, but not in this year. You'll remember, Chair, that we obviously are looking at eligibility criteria across the board in terms of prescriptions, in terms of eye care, etc. But this is a piece of work that is part of that. And obviously, we don't want to, and we've talked about this before, excuse me, but we don't want to bring everything in one go, because that would be a great deal to individuals. But we want to try and maintain, obviously, free at point of care, absolutely where we can. But sometimes there might be eligibility criteria might be applicable. But of course, we would consult on that and with the wider public on, and that is obviously a next piece of work that's going to be done in the next administration.
Is there any way to do it without changing the eligibility criteria? Because more people are going to shift from their private dentists, understandably, when there is NHS dentists available. So how are you going to curtail that?
I think that you're absolutely right. It's basically opening up the doors, isn't it? That which is what we've done. I mean, I think it's incredible that there's been 6,350 allocations in this time, which is a huge number. I think that's going to be a natural progression. It's policy changing at that speed. When you do make those changes, we absolutely, that was the first thing to make sure that happened, that we made the availability for people to get to see a dentist. But you are right. Obviously, at the same time, that has opened up the door. In terms of the prescription charges and things like that, that has been our first stage of the eligibility criteria. But as I said, it's not something I don't think we could do it any other way than obviously as a policy change, unless you've got.
No, I was just going to ask you. With regard to dental practice, how do you prioritise those who genuinely do not have a dentist from those moving from a private dentist into NHS?
I'll maybe let Sean answer, but then we also have our services and our backup services for emergency dental. So, which obviously have had an increased role and responsibility during this period of time when people have struggled to have access. So our community dental colleagues have provided that services, and we've managed to also ensure that our other dentists in the community are also providing that emergency treatment. So we will have a rota and availability of where people can. But in terms of that sort of allocation and access, that's something we're keen to monitor the impact of that. We always committed to understanding, have those changes really had the impact? But then also, one of the things we need to consider is who is getting the priority treatment once those allocations have actually taken place. And Sean is much closer to the detail on that. If there's anything you want to supplement, Sean?
I don't think so. I think you said it all. I think at the end of the day, it's really important that the clinical teams, look at the patients that present and manage them accordingly. And where people are not registered with a dentist, there is access to dental treatment, oral support, if they're identified as having a need, whether that's through presentation in A&E or through a telephone call into their GP. They're able to be referred into an NHS dental service that will be able to see them and treat them and register them as a patient.
Yeah, you specifically said those that are not registered, but you don't know who's registered because there is no register for dental.
Don't. Although whenever we take a patient on, we check if they are already registered in another practice, because ultimately correct clinical practice is you might have received emergency treatment through our service. We need to notify your registered dentist of that treatment so that the ongoing care in normal hours can be continued.
So, looking at the wider healthcare waiting lists, how is the department ensuring that the validation process does not simply remove patients from waiting lists without resolving their clinical needs?
Would you like me to pick that up? Yeah. So thank you, Minister. That's a really good question, and I think an important question for the public to understand. So clearly, the purpose of validation is to make sure that the right people are on the right lists for the right level of care. There are two stages to validation. First of all, there is an administrative validation, making sure that we've got the right details on the referral, that we understand that there is a need, and that the individual, the patient, still requires or believes they require the support of the service. The second part, the clinical part of that validation, is where a clinician, a specialist in that area, or a generalist with a special interest in that area, reviews the information that has been sent in on the referral and makes a decision as to whether or not actually, based on that information, that individual needs to be seen and therefore offered help and support. That individual could be supported through a more generalist route, so the clinician can provide the general practitioner or the nurse practitioner, the referring person, the therapy practitioner, with the right information to enable them to support that patient in an ongoing way, or that the patient actually has been either referred incorrectly or doesn't require the support of that specialist service. The outcomes from those reviews are then shared with the respective referring clinician and, where possible, with the patient. It's fair to say that due to the transformation delays last year, there are very few specialties that have been able to undertake clinical validation, as we haven't been able to create the work streams to allow that to happen. So the business case, the transformation business case, was designed to build that work stream of work consistently for all of the specialties. Now, there are some specialties that we have that are doing really well with this by their own innovation. So if I take gastroenterology, and again, I'm sorry, Ministers, I know you heard me say this last year. So gastroenterology were able to validate their first referral, so their initial patient referral, and actually removed 80% of the patients on that list for a variety of reasons, and my memory won't let me do that. I had the notes last year, but my memory won't. But for a variety of reasons, the gastroenterology team were able to remove patients that were on that waiting list, have been on that waiting list for a considerable length of time, actually didn't need to see a gastroenterologist. Clinically confident that there were no symptoms, no descriptors that suggested there was a need. Our respiratory consultant now, was consultants when I spoke to you last year, have removed 70% of their outpatient first and follow-up lists very successfully through validation, and Dr. Homewood has continued that process with her medical and nursing team to continue validating the patients that are on that list and ensure that they're receiving the right care and that the right patients are coming into hospital for an outpatient appointment, and that those that continue to be supported either by the long-term specialist nurses in the community, their GP, or the district nurses, or the clinical nurse specialists in respiratory medicine is actually happening. So there's always a journey, there's always a pathway. Not everybody needs to see the one or two individuals who are consultants in that particular specialty. And there are some real success stories that we've had, but I would have liked to have sat here today and said now all the others are well underway, and regrettably they're not. So you will be aware of the media and public awareness around the ENT service. We are looking at that service. It's one of the things that I'm dealing with right now. It's hot in my inbox at the moment, with a view to trying to support the 2 ENT consultants to be able to do more work in that area and manage the very, very long waiting times in that area. And cardiology is the other area that we did make a start on a year ago, but again, because of the lack of transformation funding, we haven't been able to put the investment into cardiology that's needed by that team of 3 consultants to actually do the work they need. But I'm very hopeful now we will get traction on that going forward this year.
I was just going to bring that up actually, because there's over 2,000 patients on the ENT waiting list at the minute. So I assume that hasn't been validated.
So 100 patients have been validated, but unlike the other specialties, only 0.5% have been given a decision other than remaining on the waiting list or having their priority escalated to needing more urgent care. That is a little bit disappointing, but it's just the nature of validation. And again, we now need the resources to be able to correct that waiting list position, because one of the outcomes is actually you need to see us urgently. We need to get you in more sooner than you had originally or we'd originally thought, and we need to be able to respond to that when we identify that. It's very much a clinically led service. It does work. We've got to be able to maximise it.
Are there risks to patients on that list who are not being prioritised that really need to be, but they're in amongst the 2,000 somewhere that aren't kind of coming to the surface?
Absolutely, which is why in consultant job plans moving forward, we need to build in a culture whereby there is clinical validation of waiting lists on an ongoing basis. So ideally an exercise which happens at least twice a year, but there is complete clinical ownership and oversight of consultants' waiting lists. So that's the accountability that we want to try and achieve. So actually our clinicians are front and centre in knowing exactly who is on their waiting list. There's a clinical assessment and triage about new referrals coming in, and there is that constant review of who is on the waiting list and how to expedite when needed. But clinical validation, I cannot stress the importance of it, both in terms of ensuring that we have a clean waiting list so we can accurately report on the numbers on the waiting list and waiting times, but also so we know we are managing those patients who are on the waiting list as safely and as effectively as possible. And like I say, it is an important piece of work. We would have loved to have had the transformation funding in last year to have been able to have done more in last year, but I'm pleased we have at least got it and can do that piece of work in this year. That did link to Restoration and Recovery 3. Obviously, we had the funding for Restoration and Recovery 1 and 2, which was particularly around the cataract waiting list and the elective orthopaedic and general surgery list. It was always intended that we would do this piece of work through Restoration and Recovery 3, because that is the front end of the waiting list is where we've got the biggest numbers. Once you're actually listed and scheduled and added to a waiting list for a surgical procedure, the waiting times are much, much shorter. It is that long wait at the front end of the pathway, which is what we always intended to address through R&R3, but the validation coming first, so we can make sure that exercise is done as cost effectively as possible.
Just on this, I'll come back 'cause, on this. Do you understand the frustration that I've had a couple of constituents get in touch with me in the past couple of weeks where they go to their GP and said, you are going to need this particular procedure or a hip replacement or something, but there's this long a waiting list. Have you considered going private? And GPs actively saying, have you considered private, leaves these two constituents who paid in all the time feeling pretty insulted.
Absolutely. It's absolutely not ideal. It's very frustrating, and it does come back to, this is why it's really important we have clean waiting lists, because actually patients can then make informed decisions about how long they're going to wait, or even if they would want to consider going private. It's very difficult to do that when they actually don't know how long they would be waiting for. There's a big difference between waiting perhaps 3 months or perhaps 12 months. And it is really important we're able to ensure that we are publishing and reporting clean waiting list data.
Is it right that the GPs are encouraging people to go private?
No. Well, I don't believe so. I don't believe so. That is a relationship between a GP and their patients, and I think what a GP may be doing is just ensuring that patients do have that choice and understand the routes they could take. But I would be very surprised if our GPs were particularly promoting private practice.
Going to move on to adult learning and...
Sorry, Minister, before you do that, may I just...
Sorry, yes, Mr. Stacey, you were going to come back.
So I think there's two real important key messages. So the first one is that if you're a member of the public and you're on our waiting list and you feel that you've been forgotten, either flag it with your GP or flag it with the secretary of the specialty that you're in, because it's important that we don't forget you. We do want to treat everybody in a timely way. That doesn't mean that the wait will be reduced, because ultimately there is a list and it's date ordered, but it may mean that through some validation your clinical priority may change, or in fact you're reassured or assured about not requiring to wait any longer. My second point, which is really important, we've taken some action despite the transformation funding. So we've now put first contact practitioners in mental health, and we've been doing so in orthopaedics for some time. Not all the GP surgeries have engaged with our consultant associate specialist who is out there seeing patients, but that has made a significant difference to orthopaedic waits and continues to do so. And our first contact physios have also made a significant difference, because again, surgery, joint replacement surgery is a last resort, and it should only be done when it's absolutely necessary, and sometimes exercise and other things are actually more of a way forward and more of a way of managing pain. And with mental health, often there is no need to wait to see somebody. You can see somebody in your own constituent, in your own practice, in your own area, and so the first contact mental health practitioners that commenced I want to say 3 months ago now, after the pilot was done in the North of the island, should be, I hope, helping those people with a mental health need to receive care. So I think we've also made, despite all of the difficulties, we've made quite significant inroads into some areas of care around waiting list management. It's still not right, and as Teresa says, if we've not got clean lists, it's really difficult to publish accurate waiting times so that people can make informed decisions about the care that they need. And so we're really desperate to get on with doing that work and ensure that our clinicians own and know what's on their waiting lists.
Thank you. I will move to adult learning disability services and advocacy now. And during Tynwald in May 2025, the Minister provided an update that the Department would work with providers to commence independent advocacy services by the 1st of April 2026. I note, though, that there's no mention of advocacy in either the current mandate or indeed the operating plan for that period. So for the same period, it states that third sector partners often provide specialist services, including disability advocacy. So has an advocacy service now been successfully established?
So the tender exercise is currently underway, and I understand the expressions of interest. We're invited in March to identify interest in providers with experience and proven track record. In April, organisations that expressed an interest were then invited to complete a pre-qualification questionnaire to assess the capability and resources, and analysis of the pre-quality questionnaire responses and associated governance processes are currently in progress. And a decision at the next stage of that progress will be advised to any of the bidders by the end of May, which is a couple of weeks away. I don't think there's anything else to add in terms of that.
And in terms of to aid in delivery for the future of learning disability services on the island, can you just give us an update on the progression of that work stream?
I'll start, Minister. Yeah. So, following the commissioning of the Cordis Bright review, Department and Manx Care worked really closely together on this over the last 12 months or so, and a strategy group is up and running and working through the different work streams that sit underneath that. I'll ask Sean just to talk a bit about what those are, but in really big picture terms, that's about making sure that residents with learning disabilities are at the forefront of our change management processes as we go through this financial year and the next one. And it feels to me like we've made a good start. Sean, do you want to just add to that?
Yeah, so the team have been working really hard since the report came in to progress the way that we care for people with learning disabilities here on the island who are in our care, who are under our care. We have identified some further constraints that we need to work through with the department around housing and ability for independent living by people with adult learning disabilities who want to live independently. We need to conclude that work. But for the main, we now have a structured profile, understanding the individual needs of individuals, and we have done a lot of work around making sure that housing arrangements are not restrictive in their practice. There are still some restrictive practices because not all of those needs are yet met, but we're working really hard to do it. We've put a training programme in for staff, and we've looked closely at staffing levels across the homes that we provide care in and are making adjustments to those staffing profiles to make care more optimal for those individuals in our care.
And just finally on that, Chair, we've got a new Assistant Director started with us relatively recently. I think she's made an excellent start, getting some fabulous feedback, and they'll bring fresh eyes, new leadership into that space as well, so we can continue to drive that forward, and it's something the Department's extremely keen to keep the progress that we've already made.
If I could just return back to Mr Glover, you mentioned that it's not in the mandate. That's because it has been directly commissioned by the department as opposed to going through Manx Care, which was why it's not in the mandate.
Is there a reason why the department have taken that on rather than Manx Care? Or?
I don't think so. I think it's just something that I think we're obviously moving into with the governance review in the sense that there may be certain scenarios where we will commission directly, and I think that's important to keep that flexibility.
Yeah, I think here it absolutely made sense because of the connection with the Capacity Act, And those two programmes of work absolutely go side by side. And of course, advocacy doesn't just sit with the provider organisation. Advocacy happens in all of our arenas where we are supporting individuals to have their views and their voice heard, and that goes across all of our systems. And as I say, the link between the implementation of the Capacity Act and advocacy is absolutely key.
It's important that advocacy is obviously independent, and it would be a conflict of interest if Manx Care were providing that.
That's right. It should also go throughout the whole of the system. So by the end of May, what stage of the process will you be in at that point?
So obviously the next stage, as I said, to advise the bidders by the end of May. But I can certainly let you know following that what will happen. Okay, and is that right across the service? Specifically mental health. I mean, the Mental Health Commission have been calling for independent, particularly for those who are detained. Absolutely.
This is a real priority for some people.
It absolutely is, Chair. Sorry to cut across you there, Minister. I think in the initial analysis we did for this piece of work, around half of the caseload were open to mental health services of some kind or another. So I couldn't agree with you more. Teresa's right. We want this to be a service that can be accessed by as many people who need that advocacy support. But yeah, about half of the caseload we're looking at. So that will be a key feature as we commission.
Thank you. Okay. So move on to mental health and CAMS now. Do you want to start?
Yeah, the Isle of Man Constabulary adopted the Right Care, Right Person strategy back in 2024-25. How is it working, and has it been successful ensuring those in need are conveyed to a health-based place of safety rather than police custody?
Yeah, so Right Care, Right Person was implemented. I think it's important to say we have always had a very good relationship and work incredibly closely with the constabulary. We work together in the multi-agency safeguarding hub and in those arrangements. And essentially, Right Care, Right Person means that the constabulary, if they are responding to a matter, have prompt access to a mental health professional who can advise, and obviously there are the appropriate places of safety. We have strengthened the pathway in terms of the ability for the constabulary to contact the crisis team for immediate advice and support. The use of sort of the red phone model, so it's a priority call with a priority response, and I think that is working well. We obviously, in response to Right Care, Right Person, did take the step to place a mental health practitioner in the Joint Services Control Room to see whether that improved things. So I think the initial activity levels reported in the Chief Constable's report did indicate there was particular demand for that. So we agreed to pilot a mental health practitioner in the ESJCR. It didn't prove to work effectively. It wasn't an effective use of resource. The numbers of calls and diversions to that mental health professional wasn't particularly high, and therefore we reverted back to the model and just strengthened the pathway, which appears to be working well. I don't know whether there's anything else Sean wished to say on that, but I think it also expands. So it also expands to the organisation being clear on its responsibilities for managing perhaps missing people. So the example would be if a patient left a ward at Nobles, we would initiate an initial response using our resource, our site team, our porters, before we rung the constabulary. So again, it's that working in partnership, but being also incredibly respectful that we will have policies and procedures in place before we revert to contacting the constabulary. Also work on zero tolerance, violence and aggression, and again that sort of practice around being able to manage challenging situations which present in a healthcare setting without the necessary need to contact the constabulary, which can be anti-therapeutic often for the individual involved.
Can I just add to that, Chair? It's worth saying, Teresa, that this has had good visibility at the Safeguarding Board over the last number of months, and for me that's a really important aspect. So obviously got a multi-agency representation around that table, and there's some really good quality conversation being had at that board, but also really strong support for this model. I think it's important just to flag that.
Thank you. So the 25-26 DHSC department plan included a target of January 2026 for the new wellbeing and mental health strategy. When is that envisaged to be published, developed?
Thank you, Chair. Obviously, we've had a lot of pressures in terms of what we've been dealing with in this year. So unfortunately, that work remains in progress. The department is conscious of ensuring obviously the development of that publication and a strategy that fully aligns with the developments across the system. So, for example, Public Health launched its 25 to 30 strategy in quarter one and will be launching in quarter one in 2027. We'll do a refreshed suicide prevention strategy. But this will provide an opportunity to ensure that action plans are evidence-based around that and appropriate and proportionate to the needs of the island's population. So it has been down due to resources. We have very finite resources within the department. It hasn't progressed as quickly as I would have appreciated, but it is still absolutely a very big top priority for us.
Okay.
Chair, if I may just add to that, so as I'm sure you may be aware, in the governance review, which will come to Tynwald in June, we're aiming to tackle that issue. So I think we've been very open about the limits we have. We've got a fabulous group of staff doing their absolute best, but we are sometimes caught well short in terms of the capability and capacity we need to deliver some of these really, what I would call big ticket items. But we're aiming to address that as we go through the summer and into the autumn. So watch this space, Chair.
Thank you.
The recent announcement about the expansion of the mental health first contact practitioner service is obviously welcome. What benefits did the pilot show, and how will the impact of this service be monitored going forward?
Yeah, perhaps Sean will take this one.
Okay, thank you. Yeah, so I think what we learned from the pilot experience was that there was a lot of activity being undertaken in general practice that was able to be supported more locally and more closely at home, and the first contact practitioner was able to develop good relationships with those individuals and therefore reduce the need either for further secondary care intervention, so further interventions by mental health crisis, prevented crisis from occurring, and also reduced the number of individuals that were needing to see a general practitioner or a advanced clinical practitioner in general practice, creating additional capacity within that surgery. And for that reason, we then have rolled the pilot out across the island with a view that we will begin to see that picture happening everywhere. So we've taken a baseline of where we are from a data perspective, and over the next 2 quarters we'll be looking at the impact on both general practice appointments and also the impact on crisis and access to acute mental health services in the same way as we did during the pilot for the northern part of the island, and we'll be able to report back on that in quarter 3 this year. So towards the back end of the winter period, we will be able to demonstrate the benefits of that service around that time.
And mental health, they really did report, and speaking to Ross, that when Peel obviously was first introduced, they did see a reduction obviously in acute services, which was we expect to see with these 9 practitioners. This is really positive news. And this service in itself will make a huge impact onto acute services, but also patients being able to access that care closer to home, which is something that we've been talking about since I've been minister with Teresa, about that shift, and moving care closer to home is so important, and this is absolutely the strategy and the way forward, that healthcare needs to be provided. So we will obviously, I think, if I can take the opportunity to just say that what this will provide is one-to-one consultations with expert mental health assessments, advice and support for common mental health concerns, concerns, brief and short-term psychological interventions where appropriate, medication reviews and care planning, and also signposting to community-based mental health support or referral to obviously specialist secondary services if required. So that's really going to make a huge impact across the island, and I think this is a really positive step. I don't think it quite got enough press because I don't think people really understand unless mental health really impacts you directly, but being able to get that support locally at a GP is a huge step forward in bringing care closer to home, and I absolutely commend the pilot and obviously the results of that has proven that we needed to move this and transition that service out into the wider public.
Yes, I think we'd absolutely agree with you there. That switching to the right practitioner at GP level gets the person in the right place, but also saves GP time.
Yes, absolutely.
Okay, so now our next question is, you shared the Manx care policy for risk assessment and management of self-harm and the prevention of suicide with us. In line with best practice, it notes that standard high, medium, low risk assessment should not be used. Instead, risk is best summarised in a formulation captured via a DICES risk management plan. Can you just explain what DICES is?
Yes, Chairman.
Sorry, Sean.
As the mental
Briefly.
health nurse on the panel, I would feel wrong if
I'd give you a go.
How do I put this into plain English? Basically, what you're trying to do there, what you're trying to do using that approach rather than a high, medium or low, is effectively determine, firstly, what the individual is experiencing. Then what the outcomes from that experience will be. So are they going to harm themselves, harm others? Are they simply in a phase where they need support to get themselves out of their particular perception, their particular feeling? It therefore means that you can provide the right level of intervention, the right level of care, rather than just basically putting people into a group and a package, creating potentially a lot more dependency on chemicals, so drugs, rather than chemicals, on drugs, or creating a very heavy dependency on talking therapy. It allows you to get a balance of what an individual might need. It's also something that can be adjusted through the therapeutic intervention. So it's constantly changing rather than, once you've put a label on somebody, it's always got a label. Does that help?
Yeah, and I think it's really important to say with the Mental Health Act, we should always ensure that we are using the least restrictive routes.
Yes.
And so that sort of the use of other protective factors, the involvement of family and friends in that is all part of that assessment, because this is about keeping people safe, but using the lowest level of restriction in order to not deprive them of their liberties and to support them accordingly. So mental health professionals are always balancing those risks in every assessment they do.
Can I just get some clarity on that? Because the policy states that patients assessed to be at serious risk will be offered a follow-up appointment within 72 hours of assessment, the initial assessment. So does that, is that all cases? It's not just those that have become inpatients, it's all patients?
Yes, because remember, again, going back to Teresa's point, so we don't provide all mental health levels of care in hospital. Mm-hmm. Actually, a lot of mental health care is provided closer to home, and so often these individuals are able to be managed at home where their risk to themselves is determined as such. But in the case of an individual who is identified as requiring that frequent intervention, then the team are able to provide and offer that frequent intervention at home.
There is a really important piece of work that is happening at the moment, because mental health have previously always used something called the care programme approach, which is that mechanism to follow people up in the community. It's been acknowledged that does need to be strengthened, particularly in light of some incidents across in England, the Valdo-Calacane incident, whereby we need to have much more stronger support around those with serious mental illness who are in our communities, and that ability to maintain engagement with them for longer periods of time and understand why individuals in our communities may struggle with that consistent engagement with professionals. The onus is upon us as professionals to find ways to continue that engagement and ensure we understand who those individuals are in our community, and ensure we are continually wrapping around support and we understand. So things like medication compliance is hugely important, and we need to make sure we have mechanisms to ensure those with serious mental illness who are living in our communities are compliant. So that whole engagement piece is really important, as well as knowing who those individuals are. And this then comes back to the appropriate sharing of information with other agencies who those individuals may come into contact with.
So the measured target for the percentage of patients followed up within 3 days of discharge from psychiatric inpatient care is 90%. And you've been reporting on this since April 24, and for the first time, the target's been met just recently in March 26. So how are you going to ensure that you maintain that target?
I think this is the new policy framework coming in around the replacement to CPA. So workshops have been held with teams, recognising with professionals there are a multitude of reasons why engagement is difficult, but actually finding those range of engagement activities and just the visibility and the intelligent sharing. So the policy does absolutely strengthen that, and the training is about to be going in with our teams. The new policy framework will come to the board for sign-off. It was really important that we built this within the service, because they know their clients well, and they can add to the number of opportunities and mechanisms that exist in our community. And one of those really important mechanisms is the involvement of the third sector, the voluntary sector, because individuals may sometimes struggle to have a consistent relationship with statutory services, but those individuals will probably have a really good relationship with voluntary and community services. EdSpace, for example, have worked with us really closely on this piece of work, and on suicide prevention. And their insights are really helpful. Yeah. And also the community's eyes and ears. So again, recognising that the community have a broader role and they can raise concerns about people.
And just to add to that, so the department is responsible for the legacy grant system for those third sector organisations, and currently the amount of spending equates to about £270,000 a year that we would support. But we are looking, as just to give the chair and the committee an update, and the department is working cross-government with the Health, Learning and Social Policy Board to develop a more formal arrangement with the third sector and funding models to align with more strategic objectives. So we are looking at a new model being implemented by April 2027.
I think, if I may, Minister, I would just add finally, the development of the hubs in each of the locality areas across the island will further support this. I just want to pick up on the point that Teresa made. A lot of this is around relationships, and it is about having that obvious visibility, to prevent people harming themselves or harming others. We really need both multi-agency and also across the community to have opportunities to identify that there may be a problem, rather than just it all being dependent on data and professionals. And I think we just need to be clear that data still remains in this particular area a really difficult area of resource, so that you can actually identify where pressures might be occurring. So that multi-agency working, that hub, that community hub working is really, really important in support of these individuals.
What follow-up is offered to those who are not inpatients, and is this being achieved? And to what extent are families and carers involved in the assessment process for those at risk?
Yeah, so I think in terms of following people up, it's really difficult in terms of reporting on the success of that. But wherever possible, everyone who has reached out for help or has received help and then disengaged is contacted to try and continue that engagement. The team do that within a 30-day period after any initial intervention, but it doesn't necessarily directly relate to that intervention either being unsuccessful or relate to any unsafe multi-agency reported action. So the team may well actually contact somebody sooner than that 30-day period if others are reporting that there is harm. In terms of reporting on the successes there, it's really quite difficult to identify the success story around that. I think that's probably all I can provide the committee with at this stage.
I think I can just add to that, the crisis response team and the home treatment team are consistently meeting the mandated targets. So at least 85% of referrals from the emergency department to CRHTT are responded to within 1 hour, and 100% of referrals from the general hospital wards to this CRHTT responded within 24 hours.
I did ask as well just about the families and carers and what role they play within the actual risk assessment of someone.
So they are an important part of the assessment process. So there is the individual, but there is the information from family members, close family members, and the wider professionals that may be supporting the individual. All of that goes to providing an assessment, but also goes to providing the understanding around whether the treatment arrangements have been successful or not. So it's not just reliant on the individual. Compliance is a really difficult thing in all areas of mental health, and so you have to use others to find out and to source the success of what you're doing.
It's fundamental to a high quality assessment. It's called the triangle of care for a reason. The individual, the family, and the professional. And if you have one bit of that triangle missing, you are not going to have the full and comprehensive assessment and move on to being able to put in strategies for keeping people safe. So I think that's something we have continued to pick up and work upon as an organisation, to essentially hear the family voice in the assessment process, but also as an early warning system when things are potentially breaking down. And I know that that is sometimes difficult. I think it's really hard to get that right, and you see that happen. All the learning from previous incidents would tell you that in many of those cases there has been a lack of hearing the family's voice, who know those individuals well, to respond and reflect those early warning systems, which is why this sort of replacement for CPA is again reinforcing that message around the triangle of care.
Okay, so it's been noted that former patients are an underused resource and should have involvement in staff training, advocacy and peer support where possible. So having acknowledged that, how is that now being achieved?
Yeah, I think we are. It's something we absolutely want to do, but we are absolutely far behind a lot of places who recognise experts by experience, and peer support workers has been a fundamental part of the service deliver offer. We've recently taken through our board our new citizen patient experience and engagement strategy, which again builds upon our listing of the voice, and I would love to see more work done to identify those with lived experience having a stronger contribution into our services. They are involved in recruitment panels, and they are involved in giving their experience, but I think what we absolutely need to move to is a very clear offer and a clear framework for how we embed that consistently in the organisation and make sure it happens consistently. We still have a lot of work to do when we compare to perhaps other services who have really got this right, and can evidence that they are hearing the voice of the patient, the service user, in everything that happens. So no decision about me without me, and in terms of service design, service delivery, policy framework, we need to be able to evidence how that hears the patient voice.
Can I just add one thing to that, Chair? I completely agree with that, and the department's got a key role in supporting and driving that through the wider strategy. And the opportunity for us to move to more of a commissioning approach will help us further with that, because that enables you to set the framework within which a particular service is delivered. So we can build that into our thinking as we move towards that commissioning model. I'm very, very keen to do that.
Just mention, obviously, we're in a public session as we just tackle a few other subjects. What support's available to staff and others who witness episodes of self-harm? Because it can affect them as well.
Yes, absolutely. So we've placed great importance on what's called clinical supervision. So professional supervision is there's a clear policy framework, and individuals can access that support. So they can actually talk through a particular tricky case. They've got registered supervisors. Some of that is done external with external professionals supporting that to have much more of a psychologically safe environment to be able to talk about those issues. We have staff welfare and support, and a lot of that is detailed in our staff engagement strategy. But we do recognise that in all of our work, we will all experience some distressing, and it's fundamentally part of the training that professionals do, and how we encourage people to speak about those incidents. If there is a particular critical incident, we specifically call that an incident and treat that as an incident, with the opportunity for hot debrief, cold debrief, learning, ongoing support. So there has, in the last year, been a number of incidences where we have completely recognised they are of a level of severity and uniqueness, which has resulted in us putting in that debriefing with individuals across our organisation who are particularly trained in those skills, so TRIMs.
Yeah.
Do you want to?
No, I was going to mention TRIM, and I think generally for individuals who are in our workforce who have been exposed to that challenge, there is access to psychological support where that may be required in short or long term, but TRIM obviously is the initial approach. I think also it's suffice to say that where a department has been affected, then often the department will wrap around itself and wrap around each other with support from the executive to ensure that staff are supported during that initial grieving phase, that initial difficult, challenging period of time.
So the policy identifies a number of training needs. Are all the staff identified as requiring training up to date?
I don't have the
I don't
exact
have the statistics now. I'm
details.
sorry.
Perhaps you could have a look at that and maybe
we
forward
can
it on
provide you
to
with
us.
with that position, definitely.
Self-harm can be one of the factors which increases the risk of suicide. To what extent are instances of this monitored and are trends measured as well?
Yes, I think I can take that. Certainly all instances of self-harm are reported and tracked through our incident reporting system and are reviewed. All incidences of suicide are reported through our incident reporting system and are reviewed to ensure that there's learning from that. We are contributing our local suicides to the National Confidential Inquiry into Suicide and Safety. That's a national programme, and therefore we are able to receive, we get information based on what we're reporting based against the national local centre. I don't have the details of that immediately visible to me, but we have that. So that enables us to do a local benchmark, but also look at ourselves performing against the national benchmark to ensure that we are meeting as much as we can the standards required in the prevention of suicide and prevention of harm.
This is also something the Safeguarding Board has taken a particular interest. It's on the regular updates, because obviously what we do know is around 50% of those individuals who do sadly take their own lives, they're not known to statutory services. So, and this is why public health have such a strong lead on this. And it is encouraging to see that the number of suicides per year has reduced in the last 2 years. That we had a presentation at the Safeguarding Board, the last board. And we know there is a huge amount of work going on with the reaching out to the communities and the use of the voluntary sector in our communities to really enhance that suicide prevention action plan, as well as statutory services playing their own important role.
Okay. So just to follow on from there, how does Manx Care support those who have difficulty engaging with this, with statutory mental health services?
I think this comes back to our policy framework and our training and support of professionals to continue to be curious, and our policies not to discharge people prematurely if they are not engaging. And that cuts across both safeguarding in terms of perhaps why people and understanding why people may struggle to engage. But also how that engagement, if that translates to families and children's, it's sort of failure to bring rather than it's the DNA. And it's making sure our staff have had that training and that our policies and procedures don't prematurely discharge people from services. And we seek to find lots of different ways in which people can engage. So perhaps some people really struggle to engage in certain settings. So where can we deliver appointments which are much more tailored to how and supporting an individual to engage? And that is all of the work we're doing around this replacement to CPA. Because we do recognise that we can at times discharge people prematurely, and we can sometimes lose track of people. A lot of that also comes down to MDT working, the multidisciplinary team working, and making sure that the professionals who have involvement with people are all linked up and aligned. So the role of the GP, community teams, supporting around access and contact.
And does the third sector play a part in that as well?
Yes, absolutely.
I think the only thing I would add to what Teresa's saying is as we grow the development of the locality hubs, the conversations about individuals that may have not connected with a professional group will become more widespread, and that will give us further opportunities to identify how we might intervene or might support those individuals through that relationship. So there are huge benefits to working at a locality level as well as working within, so the professional curiosity that Teresa talks about across all professional groups, so that why, how, primary contact with an individual either as a GP or as a therapist of some sort, and being professionally curious is really important, but having a forum to regularly discuss and escalate concerns is really important. You will remember, I think, when we spoke last year, I gave the demonstration of the young man in the north of the island who had presented himself to his GP practice, actually didn't want anything, but the curiosity of the practice manager led to early intervention by the crisis team, which prevented him harming himself. That kind of arrangement and that discussion happening in those hubs is really key to ensuring these things happen.
I've got a graph here, so I'm going to break it down a bit. The waiting list for CAMS has been steadily reducing since Q4 of 2024, including a reduction in the mid-2025 after the new talk service opened. During Q4 2025 and Q1 2026, this seems to have levelled off at between 400 and 500. How can that be further reduced?
It can only be reduced by further investment into the service. So the additional funding was received in order to be able to respond to the waiting list in CAMS. The team worked incredibly hard to reduce the waiting list, and we have done the analysis of essentially the cost effectiveness of that additional investment, and again I think we've been able to demonstrate a very, very cost effective use of that resource, and ultimately the commissioning of the talk service does now mean that they are able to see quite a proportion of the referrals into the service, and appropriately triage and move on to into the CAMS service. But at the moment, given the level of demand we see, one of the challenges that we're working with in the CAMS service is how do we make sure that that service does not continue to grow now that additional investment has finished. Clearly the talk service is incredibly effective and it's good value for money, and so we are looking at how we can put more resource into that, and we have agreed through our investment into this financial year the recruitment of a second CAMS psychiatrist to be able to again strengthen that offer and build additional resilience into that service moving forward. But I think it is a real challenge. Also using the Couth and the Quell, the online, I think that's also evaluated well. But we are going to see more demand, particularly when we progress the autism and ADHD strategy. What we know of the CAMS position is 72% of those referrals to CAMS have been referred for ADHD and autism, and 75% of those who have been assessed do require specialist neurodevelopmental services. So a very high proportion. And obviously we're now starting to look for this. Our strategy will mean we are much more clear around the pathways, early intervention and diagnosis. So we will continue to see high demand, even though we are, I think, using some very good alternative early help and intervention services which are dampening the level of demand into the statutory CAMS service.
How big a proportion is that? Because I mean the actual case lists that you've got have varied between 1,900 and 2,000 down to about 1,800 at the lowest. So how much of it is what you've just referred to there?
So the majority, so what's coming through CAMS as a more specialist statutory service, 72% is for the ADHD autism. So the sort of other presentations, they are able to be well managed within the talk service. And the talk service, so for example, in Q3, over 906 referrals during the quarter, 403 referrals were able to be managed in the talk service. So about 40%, just over 40%, are being well managed within the talk service, but that is leading to the rest coming into the CAM service, of which that 72% is around ADHD and autism. So those very long, detailed, very specialist assessments, which is really important that we absolutely get right.
I think the only thing I would add is that we need to recognise that will then continue through adult.
Mm-hmm. Yeah.
So the access to service in 40% of people will then probably calm as adulthood is reached, but for the remaining 60% of those individuals, they are likely to need ongoing adult support. And so, the demand is going to outweigh the capacity that is available within the service, both across children's and adult mental health. And if we then add the ADHD need into it, that's definitely going to grow. And realistically, that is something as a community we are going to have to accept, we are going to need to fund, or people are going to excessively wait for access to specialist support or access to specialist. So the diagnostic element, I think we've got a solution for. The low level routine care, the talk care, we've got a solution for. It is making sure that we can respond to more than just a crisis. We need to be able to respond to that ongoing need. And again, so through the development of the hubs, through the development of first contact practitioners, removing the low level sort of routine, it's not really routine, it's wrong to describe it as that, but the low level activity helps to create capacity. But we still need to understand that capacity for that complex work requires more time, requires longer intervention, and treatment plans are very specialist, and we need to make sure that we can make that happen. So the development of the second children's psychiatrist will help with that, but we then need to go on and develop what we're going to do around specialist mental health services for children and adults.
So demand really will then change as to what is required within the service at CAMS because of ADHD and autism.
Yeah.
So we can assume that will require more resource. How much impact do you think that will have, and are you ready for that? Because if we're not ready for it, then it's just going to create log jams within the service. How do we prevent that?
Yeah.
So
Is it simply funding and resource?
So I think that the first thing is that we do need to work up the principles of what we're going to do. For some of this work, we need to work collaboratively with other agencies and agencies across, because there is not the nature of the work and the size and volume of the work to create a specialist service for our population. So we need to look at the way of doing that. Yes, Minister, there is definitely going to be a resource need, and we need to work that through. We need to work through what that's likely to be. We need, I think, some public health involvement in describing the challenge and the demand, because the demand for this level of support here on the island is particularly high. And again, and I've said this in other meetings, when you look at the needs for young people, children and young people on the island, there is an extensive requirement for support both in school age as well as from a health and care perspective. So collaboratively, health, education and social care need to come together to describe the offer and how it's going to work. And then we need to work through the very specialist nature of that work and how we collaborate with a provider off island to deliver that work. that those conversations have begun. They need to develop into something tangible for next year that then can be measured from an affordability and a cost basis that then demonstrates the answer to your question. So what is the clinical impact by making that development? So as we did with the CAM service and its development, we developed a business case. We said what we would do. We've done that, but we said at the time, this will continue. We've now got to really do the same thing for this.
So it will come back to, and Public Health are leading a joint strategic needs assessment at the moment on this, and I think that will give us extra richness of information from which that will inform the strategy, and it will inform the strategic commissioning arrangements for how we manage this moving forward. As I say, the work that CAMS has done has been excellent in terms of addressing an immediate waiting list challenge, but actually it does not create the clarity of what that service will need to look like moving forward. But I have to commend the work and the work of Alison and Minds Matters to put this talk service together, which really makes that single point of access, allows for self-referrals, a great high quality service with responsive times, and allows the CAM service, the specialist provider, to be able to manage the high intensity work which is referred in.
I think from a department's perspective, or our involvement in that is obviously crucial and critical to this. So I've talked before in the past, not just in terms of mental health, but in terms of across the wider organisation, that demand and capacity is and being able to plan that out for the future is extremely important. So again, just to echo what Teresa and Sean have been saying about about being able to know what our strategic needs are in the future is a really important piece of work, and how we are going to fund that is equally as important. And those are conversations that we will need to have. But as I said, that is a piece of work that is ongoing, and has started looking at the demand and looking at the capacity, and us being able to put forward, working with our colleagues, what are the sort of short term to longer term plans, and then that comes all the way back down to that 3 to 5 year funding model that is so needed, and absolutely that will play. Sorry, it's very dry in this room. My voice keeps breaking. But yeah, it's that 3 to 5 year funding plan is extremely important, and all of these areas will contribute to that, for us to be able to say this is what we're going to need in the future, so that we're not coming back to a scenario and we don't keep on this sort of wheel of fortune. It's that is something that we absolutely have to stop, and we have to get better at planning ahead.
We've talked a lot about the caseloads and the urgent cases, but more generally, both for CAMS and for adult services, what sort of waiting list times are we talking about currently?
So for the specialist CAMS service, for the ADHD autism referral pathway, we're looking at around 12 months wait. It was over 2.5 years, so we have managed to reduce it. But yes, we also recognise that's still a long time to wait. Yeah. The talk service that we commission, that's doing really well, and they're able to keep up to date. So their referral to treatment time is around 11 days. So there is a very responsive service within the talk service. So an assessment within 6 days, and usually starting treatment within 11 days. So.
And is there anything else apart from additional funding and what we've already referred to that could be done to reduce waiting times?
I mean, there is always, as with all waiting lists, there is always a productivity and efficiency element, that if you are doing something called getting it right first time, GERFT, you can use the optimal ways of working, which can give you more capacity and that is still an opportunity for Manx Care. We do recognise that across some of our specialties, if we was to adopt getting it right first time, we can drive out additional productivity and create more capacity for news. One of the key areas that we have in our operating plan, if you will have seen it, is quite an ambitious plan around reducing the number of follow-ups that are seen by moving to getting it right first time, and also patient-initiated follow-ups, and really challenging whether a patient does really need to come back to clinic and see a consultant, because actually we could create a lot of new patient capacity by doing that. And some of our specialties, they would benchmark as outliers in terms of the amount of time and the amount of follow-up appointments they are having. So we are attempting to benchmark, look for internal productivity and efficiency opportunities, and then translate that back into what we could achieve in terms of waiting time reductions from liberating those appointments.
Can I just ask about one of the actions of the suicide prevention strategy was to expand crisis response and home treatment, the home treatment team, to allow separation for rapid assessment and home treatment. How's that work progressing?
So that's all captured within the alternative to CPA. To basically understand what capacity is required out in the community, how much is linked to crisis and assertive outreach. So it is all being looked at as part of that policy revision.
Okay. In 2023, you added 7 CBT trained therapists, which you said at that time would have a profound impact on waiting times for psychological therapy. What effect did these additional resources have, and are they still in post?
The majority are still in post, and we do achieve some good waiting times on our psychological therapies. So I don't have the numbers exactly, but it's a high proportion who are seen within a matter of a short number of weeks. So, and again, that benchmarks quite favourably.
We've also included psychological therapies in the roles and responsibilities of the hubs, and also, as you know, in end-of-life care and in cancer care, quite specialist psychological access is available in those areas, again, to try and help individuals with a specific need access psychological support.
Chair, if I might just return back, the Honourable Member asked about what else could be done in terms of assisting with mental health waiting lists. One of the areas that's in the mandate and the operating plan is about social and green prescribing, which obviously is really, really important. So the department has tasked the Manx Care to expand social prescribing to support groups and debt advice and volunteering, and encourage nature-based activities, walking, gardening, to improve mental health and physical health, and I think that's really important. Manx Care are looking at developing the framework around that social prescribing, and I think again it's coming back to also those third sector organisations like the Children's Centre, which I'm not sure if you've visited, but it's incredibly amazing, and getting young people out into those communities, which are those are the sort of things that obviously the talk service can assist with in referring them to those places. But it's really, really important that we shift in that way, not just for children but also adults. Social prescribing is really important. We live in a beautiful island. I know the weather's not always fantastic, but we do live in a wonderful place, and communities are really important in supporting that. So that is something that obviously that is a shift, and specifically into this mandate and operating plan that we've listed.
We are finished with the main bulk of what we wanted to do, but we've just got a few areas that we're just going to very quickly just get some answers to. It's follow-ups on previous hearings, if we may. and the shortest answer will be the nicest answer, I think, in this. Has the department undertaken any work into having the UN Convention on the Rights of the Disabled extended to the Isle of Man?
That's a very good question.
Again, if you want to follow up,
Very happy to provide a
but we'll
written
have
answer
to
on that one.
follow up in writing, yeah. In the 2026-27 mandate under the section for sexual health services, including family planning, there is a link to a service specification for the integrated sexual health services. This document states that gender care to support patients receiving treatment through a tertiary centre was to be jointly developed during 2023. Has that service come to fruition?
So currently the local pathway remains the same as of September 2024, with the UK Health Service not accepting new referrals from Manx Care. And those already on the UK pathway or the waiting list prior to September 2024 remain there. The United Kingdom, both adult and children's services are following the 2024 case review into children's services and the 2025 operational delivery review of NHS adult gender dysphoria clinics in England, and these reports did contain a total of 52 recommendations, but this is it's basically at the moment it's a watching brief for us in that
Okay.
aspect. So we have to see what the outcomes of that.
Okay. And what provisions are currently in place for transgender individuals who are seeking gender-affirming care, such as hormone therapy?
So I think that obviously the Manx Integrated Sexual Health Centre, as you mentioned earlier, has created a Horizon Clinics, which are dedicated safe spaces for trans and non-binary individuals who don't feel comfortable in accessing the MISH ordinarily, and obviously with the first contact practitioners, etc., within the GPs as well. That also will be a help to support them. Trying to keep my answers short. I don't know if you want to add anything more to that.
I think it's an area where shared care is really, really important. We don't want individuals to have to resort to buying their medication off the internet, and we want to make sure there is an opportunity for monitoring for those who are on medication. So it's one of the fundamentals of the shared care, and I meet with the group every few months, working with Dr. Mandel, to make sure we understand who the community are, who are accessing those, and make sure that we can get the prescribing correct, and that will be specialist prescribing linked under the MISH service. So
Just to just look back and reflect on this administration, really, and looking back on the last 5 years, how would you evaluate the introduction of Manx Care?
It's a loaded question.
Such an innocent question.
Do you want me to answer that? Evaluate the introduction of Manx Care. I think not to sort of go on about the Sir Jonathan Michaels report too much. I think the purpose of Manx Care has been to hold an operational side of delivery of health and social care, and I think that, from my perspective of being minister, has absolutely worked in that essence, keeping the political side away. I think the governance review plays a great part in that future, and Manx Care 2.0, as we're sort of starting to call it these days. I think we need to somehow maybe not have quite the distance that we have had. I think that's fair to say, and certainly working with my colleagues sitting next to me and wider Manx Care board and executives, there is definitely the will and the want to work closer together to make sure that we do what's right for patients first and foremost. I think we live in a very a unusual scenario on the Isle of Man, whereby we have one delivery, main delivery of care, social care, health and social care. We don't have 5 or 10 trusts that we as a commissioner could choose to provide those services from. So we must work with Manx Care, and we must make that relationship work. But I would say that it's been a real sort of eye opener. I'm not the sort of person that's sort of let's say it's over to you guys. I'm a team player, and I think that's really important for the Manx public to see that their minister is somebody who will take accountability and responsibility, even though it is an arm's length organisation, and that's how it's been set up. But the governance review will look at that relationship and look at bringing that closer together.
Is it fair to say, this leads directly to something you've recently said, in that the St Jonathan Michael's report was quite a number of years ago now, so there's a danger of being over-reliant on that, and you have also just recently said that Manx Care will look very different in 10 years' time, so I'm trying to tie in those two extremes as to where we're going.
Yeah. No, I mean, Sir Jonathan Michael's report is now 7 years old. But I think, Manx Care commenced in the middle of a global pandemic and was living and responding to that pandemic for the first 2 years. Sir Jonathan did his midterm report, where he acknowledged things were actually much worse. The baseline was much lower than when he first published his report in 2019. We have had comprehensive CQC and Ofsted inspection into our services in 2022 and 2023, which again was clear around the baseline and the trajectory for improvement and what needed to improve. Manx Care is about to publish its 5-year look back. So at 5 years, we have gone back over every year against what the mandate said and what was delivered, plus also the internal priorities that we set as a board. And I think that will tell its own story as we publish that in June as to just how much work has happened. Our focus has always been around the quality and the safety, particularly, of the services that we provide. And that has often led us to have to make some difficult decisions about what we can and can't do on the island, but how we also work incredibly closely with both the local providers and the voluntary and community sector, who are such a critical part of health and care delivery for us. So the organisations like Crossroads, like Hospice, like Minds Matters and I'll Listen, like EdSpace, the charities who support us to do the work, but also our critical relationship for tertiary care across in the Northwest. So the advances that we have made around cancer care, around major trauma and critical care, and specialist mental health provision, which can only be achieved through linking the island to those specialist centres on agreed pathways of care. We have also absolutely supported professional development here on the island. So growing our own heroes, our own talent, creating training opportunities and development opportunities for our workforce. It speaks for itself that we have reduced the vacancy rate in the organisation by close to 10% from where we started. We have implemented lots of new systems and processes, and we have got our governance working much, much better from a very low base. We understand our risks as an organisation. Data has massively improved, so we are able to give the evidence, tell the story where we can, but there is still an awful lot of work to do. And in terms of healthcare in 10 years' time, yes, it does need to look very, very different. We need to invest in strategies which are focused on keeping people well and intervening at the earliest opportunities and empowering our population to manage its own health, have the tools to manage its own health, use data and use digital to real-time monitor health. And so we aren't as reliant on the very expensive specialist services, which we want to use them when we need them, and they will always be needed. But as I say, the left shift around prevention, early intervention, the use of digital and providing care in our communities is where we will see the greatest impact.
And if I just add that that's a journey that we have started. And I know that these headliners can just say, oh, it's got to look differently, but really you need to understand, I hope the public really can hear the second part to that story, how it does look different. We are on that journey already. But I have to say, just coming back to Manx Care as an organisation, if you would compare something like the likes of the MUA, for example, not being in charge of their own IT, the central services within the government have impacted on things like on Sir Jonathan Michael's report to deliver a single patient record. And these are things that we must absolutely advance. And we're sitting here in year 5, and that report was done 7 years ago, and that single patient record is singly one of the most important things to deliver for next year. I would say it would be 18 months, but it is absolutely imperative that this next administration pick up really important factors for Manx Care to support them in that. They're not in charge of their own buildings. They're not in charge of their own IT. It's not a situation that can continue. If they are to be successful, the Isle of Man government must support and absolutely change that. And that is the governance review. That is absolutely what must happen to support the colleagues sitting next to me and the staff on the ground. Logging into 7 or 8 different systems every day, it's not acceptable. We have to change. We have to get this moving, and absolutely, it's something it has to be addressed. These issues have to happen faster. Treasury concurrence has to happen faster, and I know that the Treasury Minister currently right now has done some very fast approvals over the last couple of months to help us and support us with the Ramsey District Cottage Hospital, but we need to keep that going. We need to maintain that absolute quickness and reaction, because it's gone on far too long not supporting Manx Care to make these differences. And that just that one item, the single patient record, will help patients directly, absolutely help them. We talk about having to tell your story 3 or 4 times to different individuals across the organisation, to clinicians across the organisation. Having that will make a huge difference to the patient experience and actually, lives, etc. So that's really important, if I could add on to that as a final.
I think you've pretty much answered our last couple of questions in what you've just said, actually, but I'll just put one out to you that I think you've probably already answered, but what's the one thing you'd like to see changed or introduced in the next administration? Is it the single patient record?
Yeah, it's definitely supporting Manx Care. I think there's a great deal of I guess misinformation. That whilst they're an independent organisation or arm's length organisation, it really does. That would be the one thing I would absolutely want to see changed, a more cross-government support to that organisation. This is singularly the most health and social care is really important for our public. It affects everybody, and absolutely I would say that would be the one thing, and from that you would see things like the single patient record. You would see better work in terms of maintaining the buildings, in terms of upkeep, in terms of absolutely having a strategy around that, and being able to give Manx Care everything that they need to be successful. And that really has to happen.
And from a Manx Care perspective?
We would welcome that. We would welcome that. our focus, our 3,300 dedicated staff, is to provide the best care for patients, citizens, and I know they do that. But some of the constraints around IT, around the buildings that we have to use, the systems that we have to use, are not up to date enough and do not enable us to do that easily. And as a result, it does mean that we often spend money on the wrong things, trying to make the systems that we have work. So yeah, I would, as the outgoing chief executive, I would wish there to be a greater understanding of how health and care can be supported by the shared services, but also an appeal to invest in public health and really take the long-term view on the types of interventions that we know will save money in the long term. It is not about adopting failed models or alternative models from England. This is international evidence base from those countries who have demonstrated the effectiveness of this. So whilst there is a 10-year plan in England which is focused on community, the use of digital, and prevention and early intervention, those are three parameters which are internationally evidence-based wherever you look. And it's really important we start to promote wellness rather than just managing sickness.
Yeah.
And place the right resourcing in the right places. And the legislation to support that needs to move up a pace.
Okay. Well, so before
Do
we...
you want to?
Oh, sorry.
I think Teresa has mentioned the two particular points. I would emphasise the importance of legislation moving at the same pace as the IT. The legislation here is causing you harm, and it's causing you to spend money you don't need to spend, but more importantly, it's not enabling care for the public to be the right type of care at the right time and in the right place. And I really do not think that there is enough discussion in Parliament, in Tynwald, about that. And I concur with the support for the Manx Care record. I cannot believe that you've taken, as long as you've taken to get to here, the debates are not affecting the importance of the outcomes that will come on the ability to support an ageing population with a young population who have complex care needs that we've debated earlier in this debate that are not clear. And I think, as you've opened it to me, my final plea would be stop wish listing and constructively, through an evidence base, design health and care for the island population that meets their needs. The wish listing distracts Manx Care from being able to do what it needs to do and focuses others on criticising Manx Care for not delivering things that it can't deliver because it's neither been mandated or is financially supported to undertake. They would be my three pleas.
Thank you for that. So we haven't got any further questions. Is there anything anybody else would like to add before we close?
No, just a thank you to the committee for the best 2 hours of my Monday morning I've had in a long time. But no, thank you for and I do hope that there's some positive messages that will come from this, to help the public to understand what good work Manx Care does do. Thank you.
No, thank you. And really, that all that remains is to say thank you for your time today. And I think as a committee, we'd particularly like to thank Teresa, as this is the last time you'll be before us, for all of your contributions over our last 5 years.
Just going to say, we've been constantly here for the past 5 years. faces have changed on that side, apart
Yep.
from
Yeah.
Theresa.
So thank you, and we really do wish you all the best for the future. And with that, we'll now sit in private.